Thank you for your talk, Carrie. That was very helpful. I'm actually going to focus on a very specific question, which is how ought we to think about whole genome sequencing as part of state-run newborn screening programs. I'm not going to talk about research. I'm not going to talk about dry blood spots. Happy to do that, but that's not what I want to talk about today. And I'm not going to go through this to say that we generally have some idea about what are the appropriate criteria for screening. This is true not only in the context of newborn screening, but in healthcare in general. We screen for things typically at a time when there's something that can be done to ameliorate symptoms down the road, but that's generally what we do. There has been, and I want to acknowledge some things that I think haven't really been identified in the point here. There is big debate about what constitutes actionability, particularly in the context of newborn screening. Very big debate. Those of us from the medical side tend to think of it very much so, can you institute therapy that's going to prevent long-term harm? You know, putting someone on a low phenylalanine diet who has PKU, or give thyroid to, or thyroxine to a child who has hypothyroidism are classic examples of that. The issue about avoiding the diagnostic odyssey doesn't generally fall within the rubric of what we think we're doing in medicine, or just getting a name for the purpose of having a name. Although that's important, it doesn't rank nearly as highly as actual intervention. And yet I know that this is something that's been, you know, very actively advocated in this particular community. We also, in this area, have a history of variable reliance on history and politics. And I want to spend a little bit of time talking about this because if we don't acknowledge what's actually at play here, we can't possibly think about ways to move forward. So this is a crummy little slide that I made, but it illustrates a point. Early on in the course of newborn screening, we added tests at a very slow rate, typically 1 or 2 at a time, in part because each one had its separate platform, et cetera, et cetera. And then about starting in the middle of 2000s and ending up in 2005, we saw a huge jump with the adoption of tandem mass spectrometry. And I want to be clear here that there were several things going on here that led to this. One of them was clearly the ACMG statement, a methodology they used to decide what was testable and what wasn't, was subject to not inconsiderable criticism, but nonetheless it had a huge impact. But not to be forgotten is the fact that parents were actually very vigorous advocates in this process. And I mean, I was on the Genetics Advisory Committee in Tennessee, and there were a lot of really pretty interesting political things that led us to adopt tandem mass. And we did it ahead of the ACMG for political reasons. So we saw a big jump. Interestingly enough, we then saw the advent of the Secretary's Advisory Committee, and as you've heard from a number of speakers today, they actually have a very rigorous methodology that is actually, since the adoption of tandem mass spectrometry, has added new disorders at a very slow rate, at a rate that has, you know, for those who like evidence, seems like a really pretty good thing. On the other hand, it's pretty clear that that politics has come into play, where they think that the Secretary's Advisory Committee methodology has not been effective, and so you see states that have adopted lysosomal storage diseases, a variety of other things, through the political process, without any consideration about what the evidence base is, at least as far as the legislators are concerned, I'm pretty sure. So we've seen this going on, and so now we have the advent of whole genome sequencing on the horizon. Now, why do we think that this is likely to be coming? Well, no less than Francis Collins, published in his book called The Language of Life, which appeared in 2010, stated he is, quote, almost certain that complete genome sequencing will become part of newborn screening in the next few years. That's a pretty powerful statement. And it's a pretty powerful statement that NHGRI and NICHD have funded a series of grants that are looking at how to do whole genome sequencing. So we have a methodology that's becoming available. It's not ready for prime time yet, at least in general use, although we already have some fairly defined uses where people are using this in the clinical setting for things like diagnosing people with previously undiagnosed genetic disorders, and particularly in the area of cancer diagnostics and therapeutics. So this is entering into care, not quite ready yet, but it's coming. Now, so what does this mean for us? So we have this tool, and you've already heard that just because we have a tool available doesn't mean that we have to use it. And in this particular case, the question is, for what purposes are we going to use it? How broadly are we going to use it? Or, leaving this down the road, it may be that it is so hard to keep, to keep Pandora inside the box that, this turns out not be worth it to use this technology. Drawing back a little bit from the debate about incidental findings in research, which I realize is not directly applicable here, but we have a number of proposals that are out here about how one might look at it. Clinical actionability, defined as a clinician looks at it, or as a health policy maker looks at it, or potentially as patients look at it, whether it should be used for reproductive value. In other words, do you look for a mutation in the child and sort of in order to inform the parent's reproductive risks, because the information is personally meaningful, just because people want it, that's something, or do you give everything back? These are all options that are on the table going forward. And we've already heard that the ACMG recently recommended that when people are undergoing whole genome or whole exome sequencing for another indication, like the ones that they've mentioned, that the laboratory must analyze the genomic data for mutations in 56 other genes. I think that's the most up-to-date number, and return it to, and the laboratory must do that and return it to the clinician. Some of these are, a few of these are not actionable at all until adulthood, and many of them are not actionable at all in the newborn period. This is a really interesting possibility because it conflicts pretty direct. If this set of recommendations imported, full force into newborn screening that you have to do in addition to your 57, or whether that you also have to do these 56 other genes, then that would conflict pretty directly with currently existing norms about pediatric genetic testing. Now, I am not here to say that the current norms about pediatric genetic testing are necessarily right in all circumstances, but I am saying that this is something that needs to be in consideration as we decide what to do. Do we decide that this proposed set of this set of genes needs to be examined in the newborn period and then returned to the clinician? Now, I, as a lawyer, have to tell you that if something is given to the clinician, it's in the medical record. It just is. And so what that does for the degrees of freedom that the clinician has to try to interpret that to the parents, I think is really a fairly important thing to discuss. I'm just identifying that these are issues that we need to talk about and to ask the questions about whether this is the right way to go, or whether you might say, or whether we ought to consider the possibility that, maybe we ought to be doing the whole genome sequencing or looking for these mutations somewhat later in life. It's not as if, given the course of this technology, that we have just one shot at the child to do this screening in the newborn period, and that we'll never have that shot again. Moreover, I would say that if I had a genome sequence done at my relatively advanced age, and someone wanted to rely on that sequence 10 years down the road, I would say, no way, Jose, you got to do it again. You know, I don't want to look at this old data. But, I mean, all of these things are out there, and I'm just putting it on the table as things we want to consider. Some of the foreseeable issues we can talk about is who would be responsible for deciding which results to return. It turns out scientifically that this is really hard to decide what results mean something or not. We've heard this discussion about array testing, figuring out how to do it in healthcare delivery. Even in the newborn period, finding out who the kid's primary care provider is no small issue. And so where would you put these data? Do they reside with the state? Do they somehow get transferred irrevocably to the child's medical record somewhere? I mean, how do we think about where these data go? And would you have to re-examine them from time to time? This is a scary issue clinically. It's a complete break from anything we've ever addressed in the past. And yet there are recommendations out there or suggestions out there that once we have these data that we have to re-examine them periodically to see if our interpretation changes over time. As a clinician, this frightens me to death. As a primary care physician, this scares me to death. But nonetheless, these are proposals that are out there to think about what we ought to be doing with these data. So here's my concluding thoughts about this. Using whole genome sequencing in newborn screening, either as the sole platform or as a part of the platform, is going to require choices about what is reported and what is not. And that we are going to have to come to some consensus about what the criteria for making that distinction are. I mean, that's just going to be inevitable, and it's going to require coming to an ethical and political consensus about what the goals of newborn screening are, and sort of figuring that out. And the criteria for choosing are going to be critical. And the final question that I would raise, I've alluded to this already, is that I think a fundamental question here is going to be whether using whole genome sequencing or whole exome sequencing in newborn screening, at least until we have a very good handle on what our criteria are going to be, is going to be worth the difficult issues that it raises. And the reason I raise that question is because I work with clinicians who are avoiding whole genome sequencing just so they don't get into this. I mean, they are choosing, to use more limited focus panels, even though they might be less efficient and more expensive, because it actually allows them to focus only on the question they want to look at. I mean, so these are some of the questions that it raises. Do I think whole genome sequencing is coming? You betcha. But I think that the question that the Genetic Alliance in general, and that all of us have to address in general, is how do we fit this in within the context of the screening that is part and parcel of medicine already? How do we think of this in a context of looking at our evidence base and looking at a developmentally appropriate time, and I mean developmentally in terms of where you are in the life course, not pediatric developmentally, where you are in the life course, about when you decide to look at data for what. I think that's a question that we have to ask, certainly one that we are not unused to asking and answering in this country, but we absolutely have to ask it here. Thank you very much.